enough?
Yeah.
Yeah? So it's always a pleasure to be in Egypt, especially this time after all these months of lockdowns and all this COVID-19 pandemic situation all over the world. And I'm happy that I'm able to visit you, and let's discuss diabetes technology in terms of diabetes economic burden session. And I hope that it will be interesting for you. If you need anything from my presentation, you can just send me email to this address, which is written here, but there is no presentation. What should I do for it? Oh, great. So my email is written here. Don't be shy, just ask me and I will send you everything. Let's start our discussion from IDF poster some years ago, and it's written here that life-saving care is a right, not privilege, and technologies are also matched here. Of course, with all these technologies, we can save our lives of our patients, and they become from this state to this state. And I just want to remind you that we don't only care about target glucose level, hypoglycemia amount, no chronic complication life, but also quality of life. When we're thinking about technology and diabetes, usually first we just try to understand about all technologies around blood glucose level and insulin. CGMs, insulin pumps, flash glucose monitoring, smart pens, insulin pumps again, and maybe some sort of combination of these technologies, closed loop systems. But I just want to remind you that we have a lot, less more about all technologies around diabetes care. It's about mobile application, telemedicine, social media, internet resources, big data, reproductive technologies, and so on and so forth. And all these diagnostic measures we can use in patients with diabetes. Of course, diabetology is a very high development field now, and we have a lot of things in the past, in present, and for sure in the future. We have a lot of things around new insulin preparation, even about smart insulin. We have different ways of delivery of insulin. But I just want to remind you that also with all these old things, we need to add some technologies in patients. For example, when we're working with lipodystrophy, do you see these things on your patients? Of course, it's severe stage of this. It's not very frequent thing there now consultation. But I just want to show you the results which made from ultrasound departments of clinic where I'm working now. And of course, you can use ultrasound to understand what's going on in places where patient inject insulin or use infusion sets of insulin pump, because there are so many publications now about different types of these changes of fat tissue. And of course, it's possible to look at this during ultrasound investigation. So diagnostic techniques, diagnostic technologies can also help us with working in the patient with diabetes. What about insulin pump? What is the news here? What we can say about social burden? Of course, everybody understands now that it's very expensive, but people like it, and we need to use it. It's so easy way to integrate this to our everyday lives, of course, because it's an appropriate system and it's very effective. And we just need to be more structured for using this. Now we have recommendations for all situations around insulin pump. What should we do? What should we recommend to our patients? What patients need to do? And of course, even with all this COVID-19 era, we have a lot of things for diagnostic criteria, for diagnostic measurement for our patients, for all these things around this severe disease. And even here, we have recommendation for using of insulin pumps. And in use in this field, of course, we have hybrid closed-loop systems and even do-it-yourself systems. Do you hear something about it? Do you have such patients in your country? Because so many patients now trying to understand how can they connect insulin pump and glucose monitoring, even with these algorithms. What can I do for doing this soft for the do-it-yourself system? There are so many new technologies in this field now. The main thing here, I think, especially when we're talking about social burden of diabetes, that there are a lot of publications for now just to understand that there are a lot of findings measuring quality of life for patients using insulin pumps, and I think it's very important. Of course, what we need to know about closed loop system, especially in children, because this population is very, very difficult to care about. Of course, it was a very famous paper which was published in the New England Journal of Medicine, and with a lot of patients who participate in this trial, with good safety numbers. And I just want to remind you that time and range conception now is leading conception in diabetes care. And this study showed us that even when we are talking about time and range, the situation with closed loop system, even for small children, is very good. So we need to use it without any doubts. What about glucose monitoring system? A recent study shows that even amount that diabetes ketoacidosis is lower when the patient using these systems. It's especially very useful for pregnancy in diabetes, because if you compare insulin pumps and CGM here, of course the numbers for CGM is better. And especially during this difficult time and COVID-19 period, the patients can easily send everything to us, like it is written here, that it's my patient which is sent, it's written "Spasiba," thank you in Russian, because he is saying that because of your good numbers of blood glucose control. So it's an important part of our life now. And another thing is the wind of change, because during the epidemic of COVID-19, we changed everything, and now we can divide our patients to the emergency level. Of course, we are working as doctors, but we need to remember about telemedicine, and it's like a very huge popularity now all over the world for this technology. And everybody knows that there are a lot of companies here. It's not only a virtual clinic or something like this, it's also protocols, distance protocols, and a variety of communication tools. And of course, especially in diabetes care, it's very, very close to like something office visit to patients. But we need to use some sort of software. We can text in or email glucose profiles. We can use our own portals, our video conference, and so on and so forth. Even without patients in our office, because it's possible during these programs of software and application just goes through all data of our patients. And there's also a lot of written recommendations now, even for all changes in blood glucose level, for blood glucose monitoring. Especially, it's very true for our pregnant women, because it's difficult to communicate with them somehow. We can spread this information for healthcare professional to healthcare professional clinic, or clinic between patient with diabetes and healthcare professional. And of course, there are a lot of aims for virtual clinic, and we succeed with that. If you just ask me about advantages or disadvantages of telemedicine, I can show you that, of course, there are a lot of advantages, and it's access to quality care, convenience, cost reduction, but also some disadvantages with insurance coverage, because in Russia we have a huge problem here, less personal care, and some maybe potential loss of privacy for our patients. So individuals should be adequately trained in the use of telemedicine technology. What about social media? Do your patients use any social media? Or do you use social media? So it's true all over the world. I just want to say that, of course, it's sometimes very difficult, but there are some important issues. And we asked 300 patients in our country a few years ago, and the answers were very surprising, because even almost 1/3 of them said that use social media every 3 minutes. 15% use social media only because of diabetes. And they're trying to find their information not only from us, but also from peers, and it's very important. And almost everything is possible to find in social media for our patients. So we're just trying to find benefits from this, because it's connected with like-minded people and sharing ideas and opinions. We can learn from our patients. We can perform research recruitment, and we can talk to our patients through social media. of course with some difficulties here, but we even have some sort of guidelines for using social media for professional in diabetology. So the summary here is we still must use social media in diabetes care, but in a proper way. What about websites? As technology's issue for social burden decreasing, of course, it's possible to find somehow resources for patients, but also for healthcare professionals. And again, proper web resources in all languages are still needed. Another technology is big data. Where and when we can use it, it's about digital preservation, data analysis. Of course, it's about epidemiology, especially now for research, for algorithm. And the usage of big data will help us to understand a lot of things about diabetes. And the last issue I would like to remind you, it's a word from Jean-Philippe Assal, who said that sufficient doctor looks to the world through the patient glasses. And again here, even talking about all these technologies, we can't forget about human factors, because all this technology are used by humans with fears, with some doubts, with data overload, with technology literacy, which can be very poor, and with device commitment. And also, there is always a person behind the numbers, and a lot of things are going on in their hand. And again, it can influence on quality of life of our patients. Another story is, of course, that we use all these technology which are listed here. But the main thing is that still education, like a basement for everything we do in diabetes care. And the summary here is that we need to remember about the person behind the numbers, and continuous education in all possible way during the usage of any technology in diabetes care. And it can be a patient choice what she or he can use. This type of diary, or maybe a flash monitoring system, just a simple insulin pump with a simple insulin dosage calculating, or very difficult systems connected to several devices. But still, issue here is a lot of dreams. But Walt Disney said that if you can dream it, you can do it. So I think it's a hope here for all patients with diabetes and us as healthcare professionals. Because now, when we're living in the world post-DCT and post-UKPDS, the paradigm is changed. As we said before, diabetes is a leading reason for amputation, blindness, chronic kidney disease. But now, we can say that diabetes under control is leading reason for nothing. How we can do it? With help of all technologies, decreasing the burden of diabetes, not only for patients, but for healthcare professionals too. What I can just remind you as take-home messages: safe usage of all technologies is possible with knowledge, optimism, understanding of patients and healthcare professional needs, and attention to patient education. Thank you for your attention. Thanks all my patients for inspiration. And again, if you need my data, just can send me everything you want. Thank you.
Thank you.
What should I do with that? Just
now we have Professor Massimo and Professor Patrakeeva. Now, Professor Massimo also is online now, if anyone have a question. My question for you about, do you think that still the cost and the education is a barrier for use of diabetes technology until now? The cost and education, because many patient, old patient, you can't use the social media, telemedicine, new devices.
The cost in diabetes care is always an issue. It's true, but you know, I think that taking part in education on these devices is just a part of regular therapeutic education of our patients, nothing new, because when we are talking about education patients on insulin pump, it's just simple tips on insulin dosage calculations, simple tips about carbohydrate ratios and everything. So it's not very difficult because it's the same base for everything in education, even in technologies usage. But for now, it's even easier because there are so many online resources teaching these things. So the cost of education for these devices is not a very difficult problem now.
Long term, we can say, like the Professor Irina in the first lecture about the cost effectiveness. I think
it's
it's
still-
costly, but in
yeah,
long
it's
run, it is not cost.
It's
Yeah.
still discussable now. I just want to say that we need, because I agree with the previous speaker about value. When we are talking about value, we need to keep in mind the patient's outcome. And we are talking about publication on quality of life.
Yeah.
And there are so many now written publication about increasing quality of life on using these devices that I think it's just a question of time when we will have results on cost and value. And it's very important just to struggle for it and trying to improve situation everywhere with technologies in diabetes.
Yeah. Okay, is there any question for Dr. Yes. تفضلي. المايك يا جماعة، المايك لو سمحت يا دكتور. Wait.
Thank you for this very nice, informative presentation. I have a question to Professor Irina. You said in your presentation that insulin analog seems to be more cost effective. I cannot understand this. How insulin analog will be more cost effective than the other types of insulin? You know, many people in the world are suffering just not to have insulin, just if they could have even a human insulin, not insulin analog. I cannot understand the point.
Thank you so much for your question, but I'm not saying that insulin analog more cost effective. I cannot say this because it's not true, because many of this price, I only say that biosimilar will reduce price of human and analog insulin by increasing competition. I cannot say that analog more cost effective. The more expensive in this case, the directly cost will be more. But about it, but from my side, analog insulin give more possibility for people quality life. You know, I have diabetes. I know what this analog and was previously was insulin, and I cannot say, it's a lot of peak in human insulin, and you must be all the time in your head. What next? Prevention of hypoglycemia. But I cannot say about cost effectiveness because they are more expensive insulin.
Yes, but more expensive now. But
You
will save it.
I hope that the biosimilar can decrease. I hope, and a lot of predictable this. This is competition on market. I hope.
Either
Thank you for.
you will pay now or will pay later for complication.
Yeah, it's very important conclusion.
Yeah.
Pay now.
Or pay later.
Pay later. No, better now.
Yeah, but later you will pay, but you may not able to fix the problem. Yeah.
I agree with you.
I have another question.
Okay, another question.
To Professor Miyasimo. Could we concentrate more to show that the cost effect of the chronic complication diabetes is more and more than the cost of care, while we are spreading the idea of care of diabetes. So, for example, the cost of caring of diabetes patients, for example, per 1 month is maybe $300, but one sitting of a dialysis, maybe you will spend more than $500. So can we spread this idea while you are doing this nice program of structured diabetes care?
Yeah, we have to consider that the real cost of diabetes is related to complications. Most of the long-term complication. So anything that can be put in place to prevent late complication is cost-effective. And of course, we should not, forget about the cost of, the routine treatment. But definitely, we need to, the real value, in diabetes care is to prevent, chronic complication, both for the economies and for the quality of life of the people. What is to be considered, however, is that value it can be different in, to reach the target of increase the value is different in different settings, and then you need to consider the different condition in different areas, in different nation, in different settings, even within the same nation. So this is something that is not a unique recipe for increasing the value, but this needs to be tailored according to the local condition, and this is something that calls for a strategic alliance of all the components, both the people with diabetes, the professionals, the administrators at local level, and not just on an international of a high level.
Another question?
Can I add? Sorry.
Okay. Professor Irina, you have
Yeah, I only want to add, absolutely agree with Massimo, the main point, but I can repeat, the most is prevention and glycemic control. And now I make research about how cost strips for control glucose. And this is very interesting. It's not terrible cost.
Yeah.
But we must know this and provide this information to patients, because you must pay now than after for complication.
Yeah, great. Any other comment, professors? Okay. Thank you, professors. Thank you, Professor Irina, Professor Massimo. Thank you, Professor.
Can I add something? I would like.
Of course.
First of all, I'm very honored that I shared a session with Professor Massimo Benedetti. Because he is legend of our diabetes movement, I'm really proud with you, and I want to say big thanks from he dramatically changed diabetes care in our post-Soviet country. Thank you so much, Massimo. We remember you. Thank you so much.
Thank you. Thank you, Prof. Thank you, Professor.
If I can, I mean, I didn't expect such, a statement. Thank you. Actually, this makes me feel like a little bit of a dinosaur, but I mean, it's okay. It's okay. And I would like to apologize for not being here at the beginning of the session, but there was a misunderstanding about the timing. So, I mean, I'm glad that I recovered.
Yes,
and let me thank once again.
Professor Irina. Next year.
Thank you, Irina.